Thanks, Greg, and thanks to Structural Heart Disease Australia for the opportunity. And it's great that there's a live site in Perth, and that there are people at the live site in Perth. That's the second positive, and it's a great privilege to talk to this wonderful organisation. Thank you very much, Sharon. You're right. Who should have surgery in 2025? I thought was a better title. I think surgery is still an option for treatment of aortic stenosis in most patients. But it is an option, and I'm also a TAVI implanter and a big advocate of TAVI, and I think that there are a huge proportion of patients, or there's been a paradigm shift rather, in the treatment of severe aortic stenosis in light of the low-risk trials. So my job is to go through those who I think should have consideration of surgery first, and I'd like to show you some of our local data and then some of those circumstances. So this is our data, 6-month data from Fiona Stanley Hospital, the first quarter of last year. We still do aortic valve replacement for, believe it or not, for aortic stenosis, and this is obviously not just aortic stenosis. This is all of our cardiac data. It performs, excuse me, it's about 20% of our workload still in this current day and age. I worry sometimes that our MDTs have forgotten that the low-risk trials are still going, that the initial wins for TAVI in the low-risk trials are sort of being taken as done and dusted. And I think it is worth keeping an eye on what the TAVI trials, the low-risk trials, look like. Obviously, these patients were average age 74. They were a very selected group of patients. They were low surgical risk, randomised to either TAVI or to surgery. And the 5-year results of the PARTNER 3 were published last year. And it's important to see that just before the 3-year mark, there was a cost. This is death from any cause. There was a cross in the curves. As you'd expect, TAVI had the early win. That crossed it just before 3 years. And then surgery is doing only slightly better out to 5 years. But when you look very closely at the data, death or disabling stroke, the numbers look pretty good for surgery in the landmark analysis between 1 and 5 years. And similarly, in the death from any cause, 9.1% versus 5.9% in the period of time between 1 and 5 years. And I don't think this argument is completely finished yet. And I think we do need to wait till the data is complete at the 10-year follow-up. Having said that, I do recognise that for surgery to win in these trials, surgery's actually got to win. For TAVI to win in these trials, it's just got to be the same as surgery. Really, for surgery to be ahead or still in the game, we need to have a significant win, which probably won't happen. The Evolute trial also happened at 4 years. Looked like the curves were still diverging. This is mortality or disabling stroke. It's interesting though, I'm not quite sure how to explain it, and I know it's important not to compare trials, the results between trials, but these trials had similar age of patients, a similar entry criteria and similar risk stratification. Yet these are the surgical results in the PARTNER 3 trial at 5 years, noting this is 4-year data, for disabling stroke and mortality, was very similar to that in the TAVI curves, and certainly much better than the surgical arm in Evolute. Then a 4-year published data from the STS database of similarly low-risk patients, which also had a very low rate of mortality and stroke in the surgical patients. So I can't quite explain why that happened in the Evolute trial, but certainly the results would have been very different had those results reflected PARTNER 3 or real-world data. This is the 5-year data from the Evolute trials, and the curves have now met. We've got to keep in mind that, again, this is from real-world data, only about 50% of patients we see with low risk, who are young enough and low surgical risk, meet the PARTNER 3 criteria. Other people, the other sort of 49% would have been excluded for various reasons. And these are the reasons why I want to spend more of my time now. So who should be considered for surgery first? I think bicuspid valves are still done better with the surgical aortic valve replacement. We're getting much better at doing them with TAVI. But you can see this is a bicuspid valve, heavily calcified, and these valves tend to be much more heavily calcified. This particular valve would be high risk of annular rupture and also a high risk of getting an imperfect result with TAVI. I think there are circumstances, of course, when TAVIs are absolutely appropriate for the bicuspid valves, but we're still getting very good results in surgery. Bicuspid valves in TAVI, the results aren't as good as those in tricuspid valve. This is from Raj Makar a little while ago now, JAMA 2021. But despite being younger, the patient cohort, the rate of death was the same, if not slightly higher, similarly with stroke, as was the rate of residual AR. The 30-day mortality for all comers undergoing surgical aortic valve replacement, if you're under 75 years in Australia and New Zealand, is 0.8%. So we're still very good at doing this operation. It still must remain at the forefront of, it's got to remain an option in our thinking at our MDTs. There's very little data comparing surgical AVR plus CABG versus transfemoral TAVI and PCI. This is propensity score data of 800 patients with a syntax score. That's a score of coronary complexity or coronary disease complexity, the lower number being very straightforward, simple, discrete lesions, a higher number being complex, long, diffuse, bifurcation sort of lesions. 22 is important because under 22, you're low risk. Above 22, you're intermediate, and then above 32, then you're high risk. And for those patients above 32, again, with the limitations of a propensity score trial, those at 5 years who had surgery and CABG did better than those who had TAVI and PCI. So I think whilst there isn't a great deal of data, we need to rely on the very strong data that we have for stable coronary artery disease in the syntax trials and beyond in making our decisions of patients with concomitant coronary disease. Aortopathy. This is a surgical picture of an enlarged ascending aorta. This is the right ventricle, and it's somewhat dwarfed by this big aorta here and a bovine trunk with the innominate artery and the left common carotid artery coming here. The 5-year risk of rupture or dissection seems pretty low. The surgical criteria for replacing the aorta at the time of aortic valve surgery is 45 millimeters. It's only 0.5% in 5 years risk of having an aortic dissection or rupture. That number, however, increases exponentially as you get above 55 millimeters and becomes 7%, that should say 7% per year by the time you get to 60 millimeters. And you can expect around about 0.5 millimeter to 1 millimeter of growth for each year of life. And the added risk of replacing the aorta at the time of surgery is just not that high, between 0.5% and 1% in terms of surgical risk at the time of surgery. So patients who have, excuse me, an aorta greater than 45 millimeters should be considered for surgery first. Certainly by the time you have an indication to have your aorta fixed on its own rights, which is 55 millimeters, I think these patients should be having surgery. Young patients. This is very sobering data comparing registries in France and the US of patients by the various age cohorts. So the American guidelines now recommend those who are less than 65 with aortic stenosis should have surgery. Those 65 or 80, surgery or TAVI, and those above 75 as the guidelines should have TAVI. Not inappropriately, those patients above 80, the vast majority in both Europe and the US, are having TAVI to treat their aortic stenosis. What is scary, though, is the biggest growth rate. One of the bigger growth rates in TAVI are those patients under 65 years, such that now just short of, we're in 2020, so we're in 2025 now, of course, it might be far higher, but in 2020, nearly 50% of patients under 65 were undergoing TAVI to treat their aortic valve disease as a proportion of surgery. In California, these are patients less than 60. More and more patients are having TAVI. This is from the same paper. Again, there are plenty of reasons why a patient under the age of 60 might be having TAVI for various other medical comorbidities, but the outcomes at 5 years were far poorer in those undergoing TAVI compared to those having surgery. Kendra Grubb's done some very good work, and we're becoming more and more interested in what TAV and TAV looks like as we think about the lifetime management of these young patients having treatment of their aortic valve disease. Kendra has taken evolute valves and shown the risk of coronary obstruction about where you have to put your either evolute and evolute or S3 in your evolute valves. The green represents a low risk of coronary compromise. The red is the high risk of coronary compromise. And really only a very low S3 placed in an evolute valve had a low risk of coronary compromise, but most of the other scenarios had a not insignificant risk of coronary compromise for TAV and TAV. So assuming that TAV and TAV is an easy, straightforward option, I think is a mistake, and very, very careful planning about the next valve, if TAVI valves placed in young patients, is very, very important. Because taking these valves out is, we're becoming better at, but isn't straightforward. I was lucky to get a fair bit of experience being involved in a low-risk trial in the US during my fellowship, and this is an evolute valve coming out. You can see the tall struts from the frame are deeply embedded into the aorta and have to be sharply dissected out. So most of the time, the ascending aorta that's left behind has to be replaced. This is an S3 valve. These are easier to get out. This is a valve with endocarditis. Again, at least here you have the native valve leaflets to protect you as you take the strut out. And after that, we divide the strut vertically down and then peel these leaflets out. It's much easier when it's infected to come out. It's harder when it's not infected to peel it away. Not invariably, because of the relationship between the skirt of these valves and the aortomitral curtain and the LVOT. You need to patch. You can see this down here, that there's a hole into the left atrium with a patch going in there to repair the defect created by the adherent skirt. Concomitant mitral disease. Again, I think there's more and more work going into what to do with these patients with severe aortic stenosis and at least moderate mitral regurgitation. We know from surgery there'd been indication to fix the MR at the time of the procedure, and we're getting better at picking which patients are going to do well if we just do a TAVI and fix their aortic valve compared to the ones that we need to fix all the time. I think you can expect to get about 1 grade of improvement at the time of putting a TAVI in for AS, but that's it. And the patients with residual MR or no MR reduction do worse, especially those with primary MR. And I think patients with primary MR and at least moderate regurgitation should be considered, provided they're a candidate for surgery in the first instance, to have both their MR and their aortic stenosis fixed. Functional MR is a trickier one. I think if you've got severe functional MR, then surgery, we have far better options to be able to fix that at the time, and you don't do quite as well and only get about only very few patients got more than 1 grade reduction of their functional MR. Those with atrial MR actually did reasonably well. Again, a similar amount of reduction. We, of course, have the opportunity to do an annuloplasty for these patients or a valve replacement if necessary. MitraClip for these patients and we're getting more and more experience with, but I think is not quite as good an option as a surgical valve fix for these patients. So I think these must be kept, surgery must be kept in mind for these patients. Other patients, and I haven't put, I've assumed that these are not high-risk TAVI anatomy. I don't think we need to be pushing the boundaries with high calcified annular calcification, the risk of rupture. I really think these patients should be considered for surgery first, where we're very good at being able to calcify the whole annulus in probably a much more safe fashion. Femoral access, we're getting much, much better at getting into the femoral arteries, but we do have vascular complications which can be hard work to fix. And I think the bailout of putting a covered stent in the femoral artery certainly is not going to cut it for young patients. It's fine for an elderly patient to get us off the table, but these stents aren't without problems, especially if they occlude in the future. Atrial fibrillation, I don't think should be necessarily a deal breaker for TAVI per se, but it's certainly something we can fix with surgical aortic valve replacement. And I've got a very low threshold to do a biatrial maze at the same time as an aortic valve replacement, and also ligating the appendage. And when some patients with very large annuluses, and we're talking sort of the 800 plus annuluses here, we're really pushing the bounds of a 34 Evolut or a 29 S3. I think these patients do very well when you sew a valve in, when you sew a large valve in. And I think despite their age, I did an 86-year-old recently with a 1,000 millimeter squared annulus who has done very well, and I think would have been a high-risk TAVI. This table from Dr. Windecker in Europe is very useful for our MDT. I think age, surgical risk, frailty, valve morphology, femoral access, concomitant valve disease, coronary artery disease, and various other factors really plays a part in this complex decision-making to work out who should get surgery compared to who should get TAVI. Our TAVI MDTs are so much more interesting now that low risk has been approved, because it used to be a game of working out who was low, medium, and high risk, and therefore who should have what treatment. Now it's really working out which treatment should be better for the patient. Again, really appreciate the opportunity to speak today. Thank you.